Good morning, everyone. My name is Thanakorn Sornkupan from College of Medicine and Public Health. Autosomal dominant polycystic kidney disease, or ADPKD, is the most common genetic disorder that leads patients to be end-stage renal diseases. It occurs from the mutations of PKD1 and PKD2 gene, which are responsible for the mechanosensor and cation channel. The PKD kidney usually end up with end-stage renal disease, which is a multiple system disease and requires dialysis and kidney transplantation. So let's talk about the pathophysiology of ADPKD. The ADPKD is regulated by the cyst formation and cell proliferations, and then it leads to fluid secretion, which is enhancing by the cell inflammations. The underlying mechanism of cyst formation results in the increased tubular lining epithelial cell, which enhancing by cell inflammation, which is modulated by the tumor necrosis factor alpha and the interleukin 6. In the clinical trial, we used tolvaptan as a first-line drug, also used rapamycin and CFTR inhibitor. But we found that tolvaptan, which is the first-line drug, contained the serious side effects such as liver cytotoxicity and electrolyte imbalance. So now we are interested in the herbal medicine. The herbal medicine offers a alternative or complementary therapeutic options, and also economical and environmental friendly. The well-documented extract is the gambogic acid, which contains the ability to inhibit cyst growth and contains many biological activities. So now let's sum up that the ADPKD contains the main issues that it leads to the end-stage renal disease and can occur the secondary hypertension. Now that you use tolvaptan as a first-line drug, which can cause the serious side effects. So there is no existing treatment that can effectively halt cyst growth for long term. So is the need for the therapeutic agents such as the alpha-mangostin. The alpha-mangostin is the extract from the peels of the mangostin, which is the same genus as gambogic acid. The alpha-mangostin contains many biological activities such as the anti-proliferative and anti-inflammatory effects. So from the previous slide that I have presented, the cyst lining epithelial cell in the PKD sample regulated by the cell proliferation and cell inflammation, which is modulated by the ERK1/2 and the F-kappa B. And we know that the alpha-mangostin contains this ability to inhibit this pathway. So it leads to our hypothesis that what is the effect of alpha-mangostin for slowing renal progression. And it also leads to our objective that to investigate the effect of alpha-mangostin to slow renal cystogenesis progression. So we separate our experiment into two parts. The first part, we focus on the inhibitory effect of the MDCK seeds. And in the second part, we focus on the detailed mechanism of alpha-mangostin. In the first part, we use MTT assay to evaluate the cell viability of the alpha-mangostin to the MDCK seeds. And after that, we pick the concentration that not cytotoxic to the cell to treat in the further testing, which is the MDCK seeds growth. In the second part, we will use cell proliferation as a kit to represent the cell proliferation rate, and we use the mRNA expression of pro-inflammatory cytokine to be representative of the inflammation by using the real-time RT-PCR. And after that, we use Western blot analysis to analyze protein that relate to cell proliferation and cell inflammation. So in the first result, we use the MTT assay to approximate the appropriate dose of alpha-mangostin to treat cells without the cytotoxicity. And we found that at the dose 1 to 5 micromolar is not cytotoxic to the cell. So we continue treating in the further testing in our study that in the MDCK seeds, which is treated by phosphocholine and 3D collagen gel from day 0 to day 6. And after day 6 to day 12, we change media every 2 days. In the control group, we continue to treat by phosphocholine and DMSO, but the treatment group, we add the alpha-mangostin in the varied concentrations. And we found that at day 12 of the cyst growth, we found that at the control group is significantly distinguishable from the treatment groups, especially the alpha-mangostin is 5 micromolar, which can imply in the C graph that the alpha-mangostin can significantly suppress the cyst diameter. So we can imply that alpha-mangostin can retard MDCK cyst growth without cytotoxic to the cell. In the second result, we want to evaluate the underlying mechanism of the alpha-mangostin on the cell proliferations by using the BRDU cell proliferation assay kit, and we can imply that the alpha-mangostin can significantly suppress the MDCK cell proliferations. In the second step of the second part, we use the RT-PCR to evaluate the expression of pro-inflammatory cytokine, which is the tumor necrosis factor alpha and interleukin-6 in the gene level expression, and we found that the alpha-mangostin can reduce this pathway significantly. In the last result, we used Western blot analysis to analyze the protein that relate to cell proliferation and cell inflammation. The cell inflammation represented by the ERK1/2 and cell inflammation which is represented by the NF-kappa B. And we found that at a dose 2.5 and 5 micromolar of alpha-mangostin can significantly inhibit the expressions of ERK1/2, which is representative of the cell proliferations. And in the dose 2.5 and 5 micromolar of alpha-mangostin can significantly raise the expressions of the I-kappa B alpha, which is the counterattack of NF-kappa B, which is representative of the cell inflammation pathway. So we can conclude that the alpha-mangostin increased the I-kappa B expression and significantly retard this pathway. So in conclusion, we know that the alpha-mangostin can inhibit ERK1/2 and NF-kappa B, which can ameliorate the disease progression and also make the cyst diameter smaller. And we know that the alpha-mangostin is a multi-target therapeutic agent for the slowing disease progression. And in the future, we want to find the potential synergistic effect of existing PKD therapies. Yeah. Thank you.
Such an impressive presentation. Thank you very much. Does any judges need further clarifications?
So when you look at the cyst enlargement, when you add mangostin and evaluating the effects on cyst enlargement, did you also consider the impact on the osmolarity of the solution?
Yeah, I think this is significant to consider the concentrations of the osmotic pressure. Yeah, it's also important in our procedure. It's like advised by my advisor. So it's like this pathway is like prudently observed by me and my advisor. Yep.
For the range of the concentration of the alpha-mangostin that we are using, it seems to be relatively high. Like 5 micromolar for cell treatment is actually extremely high for the cell treatment. So have you, like in the previous pilot study, have you like expand the pilot ranges of concentration, and how about those results?
The reason why that we pick up the dose 5 micromolar of the alpha-mangostin because in the previous study on the literature review, we found the maximum dose that used in the research is 10 micromolar, and we use the MTT assay to evaluate the cell viability. As I told you before, this one maybe. Yeah, this one. We start from the 10 micromolar of alpha-mangostin, and after that we vary concentration by diluting from 10 to 5 to 2.5, and we found that at the 5 level is non-cytotoxicity to the cell. So we pick up this dose to treat in the further testing in our study. Yeah, so in sum up, it's like we follow the protocol from the previous study. Yeah.
Any comments or any questions? Thank you very much.
Thank you.